And Dr. Saili is a senior fellow, and she's worked on PRK pain. It will be very small, few minutes presentation, and then we will end it up. Any questions?
So this might not be related to this topic. So your experience in refractive surgery experience in patients with Gatte. Do you do refractive surgeries on them, and which would
I
you?
do avoid, because I have a policy. When I don't know what it is going to happen, I avoid. Because the problem with any refractive surgery is outcome of poor outcome will not be immediately measured. And if you know that if you're documented there is a gut and you do it, and tomorrow the patient comes and says that there's no report of being having a safety on doing it, then it's a risk. If you desperately need to do it, do a PRK, because you'll create a scarring at least there. Tomorrow, it will create a barrier for any kind of epithelial changes.
Thank you.
Uh, Try to be very concise and quick so that it's just talk about this. So we have only few minutes left.
Yes. So I'll keep it short. We already know, sir has already discussed about how PRK pain is one of the major challenges that we're facing. And although we have a lot of management modalities, most of them are limited by undesirable side effects. So we need an effective non-pharmacological means of pain management, which is the need of the hour. And our previous venture into this considered ketorolac soaked bandage contact lenses, which did help us improve the pain scores that we saw in our patients. But we wondered if we could better these results. So that led us to looking into the history of cold as a therapeutic agent in sports medicine and cancer medicine, etc., and which brought us to a research question of whether refrigerated bandage contact lenses would be the answer. So we performed a small study with both PRK patients and keratoconus patients undergoing manual cross-linking, and we divided each eye being treated into two groups: the conventional group, which received the room temperature BCL, and the cold group, which received BCL stored at 4 degrees Celsius. And this cold temperature was maintained by removing the BCL just prior to placement on the patient's eye after ablation. So all of these patients were randomized into these two groups, and pain was recorded on the first, second, and third postoperative day. And clinically, we did get excellent results. 80.4% of our subjects showed reduction in pain score with the cold BCL, and 19.6% showed no difference. And similar results were seen in the keratoconus group as well, with no significant difference in the epithelial healing and no signs of infection. So we knew that clinically this was working, but we wanted to understand it at the molecular level. And that is why we dabbled into the molecular aspect of this by assessing the transient receptor potential ion channels, which are temperature sensitive channels, mainly the TRPM8, which is associated with cooling, and also the inflammatory receptors, including the CGRP and the IL-6. So what we tried to understand was whether these receptors could be identified on the undersurface of the bandage contact lenses, which we retrieved from these patients. And again, the patients who were undergoing bilateral PRK with cold BCL in one eye and conventional in the other, we collected the BCL from these patients. They underwent a series of experiments, and we studied the normalized gene expression. Now, here's what's interesting, that the patients who showed a good response to the cooling, the patients who reported reduction in pain with cooling, they showed an increased expression of the TRPM8, which is known to be an anti-inflammatory molecule, which which is associated with cooling. So we did get a good clinical results, but they also reflected in the molecular pathway by showing an increased expression of the cooling receptor. So we obviously have a lot of theories as to why this could be happening. The most popular theory being the gate control theory. So basically what it says is that there is dampening of the pain because of the intense tactile stimulation. So basically when what we see is when a child gets hurt, he immediately tends to hold the area that has been hurt. So your tactile sensation can dampen your pain sensation. So that is what the cold is doing. Another reason could be the reduced nerve conduction velocity, reduced sensitivity to pain receptors, and the decrease in the metabolic rate, causing a decrease in your inflammation.
Sally, 1 minute you can go back.
Yeah.
The few things which we can discuss from a practical point of view is, say, if tomorrow if somebody wants to do this, what do you tell them? How do you maintain this cold chain to make this happen?
So the most important thing is that the temperature is not going to last for very long once you remove the contact lens from the refrigerator. So it's important to keep it in the door of the fridge. We don't want to freeze it. We just want to maintain it at an ideal temperature of approximately 4. So it is essential to keep it in the door of the refrigerator overnight and
And this
right
is
after the
important.
ablation.
Overnight is important, not
Yes.
keeping it for 1 hour or 2 nights. So if it has to work, you have to do it the right way. The one first point is overnight. The second point,
The second point is that it needs to be placed on the eye just after the ablation. So remove it from the fridge just before you're placing it over the eye. Even 1 or 2 minutes here and there, the BCL will probably lose the temperature and it won't have that effect anymore.
perfect.
So
So it's one is overnight. Second is you don't keep it outside. Many times the technicians would keep it outside, and that effect is lost. You just tell them that you just bring it immediately when you're just finishing the procedure. The third point is uh, that minute you put it into the eye, the body temperature should cool it down. So, based on your work, how do you explain that your pain response is so controlled that most of them and have Wong take a score of 1 or 2, which is something similar to what we see in LASIK patients. So, do you have a explanation for this? That why should is it related to the cold itself, or it's related to the how it's modifying the pathway of pain?
So, obviously, the cold temperature itself is not going to last over more than a few minutes, and that is not what is causing the dampening of the pain. This is where the molecular aspect of the study is important, where we showed that the cooling receptor was increasing in its expression because of even a momentary application of cold. So, that is where the answer lies, that it is not that the cold is acting over 3 days, but even the momentary action is causing a decrease in your influx of inflammatory mediators, and it is causing an upregulation of the pain sensitive receptors. That is what is lasting over a period of 3 days. Of course, if the pain, in some patients, if they do show an increase in pain after a day or so, you can always replace it with another cold bandage contact lens. But in most of our patients, we didn't feel the need to do that because this was acting at the molecular level. It wasn't just the temperature that was the answer here.
Basically, it's something similar to antibiotic drops, or at a very early stage, you treat it with the most moderate amount of drops. This whole sequelae of event, which makes the bacteria to multiply, grow, and then all the other things which happens, can be knocked off. Exactly, the cold works on the same way. It's not the cold of the contact lenses. When you put a cold lenses, it knocks off all the pathways which actually cascades into a reaction. Your reaction is blocked, then the cascade gets blocked. Even though the temperature goes back to normal, you have blocked that chain of events which would have probably caused pain. And the chain of include pain, she's mentioned so beautifully about the inflammation and TPRV channel, which is goes up, which regulates it. So it's all more of a regulator of wound pathway, I would say, not a cold as a cold pack, whatever you can, just to give a mechanical effect on that. Am I right?
Yes.
Perfect. Thank you.
Thank you.
Pardon? I think, I think, to be very frank, we tried for few hours, uh, one day. It's not overnight. If you're doing it in the afternoon, evening, you can keep it in the morning also. It's just that we needed that 10 to 12 hours. I think that's how the material of the contact lens would change. We used that. The study what she showed. The paper is out in IGO this month. You can read that paper. It has 4 groups, 4 randomized groups, and we use cold and BCL, no cold, just the cold BCL. Multiple groups were done, and we figured out. Yes, exactly. We have done all that. The paper has everything. You can download it. It's online. It's already online. Thank you, and thank you all for.
So one question, please. Can
Yes.
you maintain the pathway by putting post-operative drugs, drops, which are kept at 4 degrees centigrade?
Uh, you can try it, but there are challenges with drops. NSIDs has its own challenges, so we thought this is much more simpler than using anything. And we have never used any drops on this.
Yeah, because the drops can always be stored at 4 degree temperature.
Yeah,
and
drops
they
drops can also be. Yes,
post-operative
we use
medications
cyclosporin.
that would probably maintain the pathway which you have, explaining.
But the in PRKs at least the epithelium is off, so there'll be some contact lenses. But using drops, keeping the drops in fridge, especially cyclosporin, reduces a lot of.
At 4 degree temperature, you can store it and keep it later. Use it later on.
Thank you, and thanks for coming.